Good morning and welcome to Tuesday's special case presented by Nuraimi. I'm a resident year 3 family medicine. Today I'm gonna talk about occupational diseases. Why I talk this topic for emphasize doctor for asking history of work about our patient. Today I divide four parts. The first part is diseases caused by chemical agents. Second part is caused by physical agents. Third part is occupational respiratory diseases. And fourth part is resources for repeated before examination. I begin with question and followed by answer and mini topic review. First part is disease caused by chemical agents. Question number 1. A 50-year-old male ammunition worker ทำกระสุนปืน presented with discoloration of lower gum for 6 months without any pain or abnormal chilling. What is the diagnosis? Wow! What test would you order or to confirm or rule out your diagnosis? A. Capillary blood lead level from finger stick. B. Abdominal radiograph. C. Venous blood lead level. And D. Erythrocyte protoporphyrin or zinc protoporphyrin level. The answer is C. The diagnosis is lead poisoning. How to diagnosis? First one, very important, is lead exposure history. 2. Investigation. For blood lead level is more than 60 microgram per deciliter, and peripheral blood smear will show the hyperchemic microcytic anemia with basophilic steeping. And the clinical presentation will be the mild, moderate, and severe. For mild, symptom is non-specific, like myalgia, irritability, paresthesia, mild fatigue, intermittent abdominal pain, and lethargy. For moderate, like a headache, tremor, vomiting, generally fatigue, diffuse abdominal pain, weight loss of libido, and constipation. And for severe symptoms like effect of CNS like encephalopathy, motor neuropathy, seizure and coma, effect of GI symptom like the abdominal colic, lead lines that accumulated of lead at the mucosal area like this case and oliguria. Decision for calculation is not depend on lead level but depend on the severity of clinical symptom. Which occupation is affect lead mining, ceramic glass or ceramic covering, ammunition maker, battery manufacturing, automobile brake repair, and jet engines. Question number 2. A 39-year-old male developed intermittent fever, loss of appetite, hair loss, and blurred discoloration of tongue and limbs 1 year before admission, followed by diffuse thickening of sole and palm, gradual worsening, tingling, and numbness of distal part of limbs, and weakness of extremity over the course of 1 year prior to admission. What is it? From the nail bed for the finger. Which work you probably do? A. Pesticide history factory. B. Glass making. C. Mining and processing. And D. All of above. Is it right? The answer is D. All of above. This is arsenic overexposure. It can cause acute and chronic symptoms and is a fact of many systems like the cardiopulmonary like edema, short EKG abnormality, GI, neuro, skin, hepatic, renal, hematologic, and musculoskeletal. Some of symptoms is like lead poisoning, but that I want to emphasize is dermatitis. Skin lesion like arsenic keratosis is the hyperpigmentation of the sole and palm. And measline. Measline is a parallel leukoplakia of the nail bed. And for the chronic symptom, is the fact of many systems. That I want to emphasize is this is arsenic is carcinogen in human. It's a fact of Bowen's disease or squamous cell or basal cell carcinoma. Ooh, why? Why? Okay. Which work is a fact? Pesticide or herbicide factory. 2. Mining and processing. C. Glass making. And D. Trading wood factory or ทำไมแปรรูป Yes. How to diagnosis, history, sign and symptom, and laboratory. The base specimen depend on exposure related to time presentation. If patient is acute exposure within 24 hours, we can use the blood and urine. The arsenic level is more than 50 microgram. If patient exposed to approximately 1 week, we can use urine. The arsenic level is more than 50 and chronic exposure urine more than 35 microgram. And for the end of the work, it can accumulate in hair and nails. By this case, you can see the means line. Okay, disease causes by physical agents. Enough. Question number 3. A 62-year-old male worked as carpenter for 30 plus years. Minimal hearing protection, communication difficulty on the TV at the pub, and has TV too loud according to family members. What parts of auditory system has been damaged to cause this hearing loss? A. Cochlea, B. Semicircular canal, C. Eardrum, and D. All of the above. The answer is A. Chronic exposure of loud noise make the damage of hearing cell in cochlea. This is a normal cell, and this is a damaged hearing cell. WHO recommended the highest self-noise exposure level is considered 85 decibel for a maximum 8 hours, not more than 8 hours. 85 and 8, please remember. Not only the noise effect of permanent hearing loss and tinnitus, but also effect of heart disease. How? For a key effect is decrease of sleep quality and quantity in it effect of hypertension, reduce of learning and productivity in the loud noise increase annoyance, stress, and distraction. So it cause of hypertension, reduce learning productivity, and endocrine disruption. So effect of long-term effect of heart disease. This is our diagram. Circle in red line represented right ear, and X and blue line represented left ear. The normal hearing is 0 to 20 decibel. If more than 20, represent of abnormal. In this case, is a bilateral sensory neural hearing loss at 3,000 to maybe 7,000 hertz. More than 53 of fishermen has a diagnosis with the hearing impairment. Okay, and third part is occupational respiratory diseases. Question number 4. A 52-year-old male who works in the hog confinement area, complaining of cough, fever, wheeze, dyspnea. He and some other workers were moving moldy hay, and they all come down with the same symptoms, with start between 4 to 8 hours after work. On examination, he is at by with a respiratory rate of 28. He is able to talk in complete sentence. There are slight crackle when you auscultate of lung. The most likely diagnosis is A. Ephemeral lung, B. Toxic organic dust syndrome, C. Reactive airway disease, and D. Hydrogen sulfide poisoning. Tick tock. The answer is B. Organic dust syndrome is a non-infectious spread by illness after exposure to the hot, warm environment. There are many humidities and accumulated of fungi, so it can cause toxic alveolitis and pulmonary mycotoxicosis. It occurs when organic dust or aerosols contain large quantity of microorganisms which are inhaled. Clinical presentation like a pneumonia, fever, myalgia, chest tightness, cough, headache, and dyspnea 3 to 8 hours after exposure. Highlight is no prior exposure required, no serum antibody detected, and spontaneously recovery in 24 hours after withdrawal of exposure. Mechanism is unclear, but may be from endotoxin, not immunological, activated complement cascade and cytokine release. Question number 5. Appropriate treatment for this patient is A. Antibiotics, B. Intubation and mechanical ventilation, C. Supportive care, and D. A and C. Tick tock, tick tock. The answer is C. Remove from exposure and supportive care. No need steroid, no need antibiotics. Which occupation? The exposure context is cotton or business, hot confinement building, and grain silos. Okay. Question number 6. These patient's brother who also work on the farm know that every time he alert hay and he has a fever, cough, dyspnea, sputum production, it tends to resolve in 2 to 5 days, but reoccur when he's re-exposed to hay. None of the other workers on the farm is affected, and they are beginning to wonder if he is malingering. His exam revealed the tachycardia and fibrosis. There is no wheezing. Chest X-ray spill is normal. The correct treatment of this patient is included A. Antibiotics, B. Enhanced steroid, C. Oral steroid, or D. Leukotriene inhibitors. The answer is C. What is the diagnosis? It's the former lung or hypersensitivity pneumonitis. Farmer's lung is an immunological mediated lung disease effect of lung parenchyma, commonly caused by organic material, especially spore of thermophilic. It's mixing in molding vegetable compost, air humidification system, and saprophytic fungi. The particle size is less than 5 micrograms, can reach lower respiratory tract and cause inflammatory of alveoli and small bronchial. Clinical presentation depends on immunologic response of host. How different between organic dust syndrome and farmer lungs? Many respects. The first one is chest X-ray does not show infiltrate in ODTs, but will show infiltration or fibrotics in ODTS and in farmer lungs, and severe hypoxia does not occur in ODTS, and highlights prior sensitization to antigen in the organic dust is not required. For the severe case, the treatment included steroid and immunosuppressant, but in this case, it's mild to moderate symptom. We can use antibiotic is effective. Question number 7. A 60-year-old man working in the brake lining factory presented with cough and chest pain. X-ray and CT test as shown. What is it? Plaque. The correct diagnosis is silicosis, asbestosis, byssinosis, or D. Covert pneumoconiosis. The answer is B. Asbestos-related disease is a factor of respiratory disease like parenchymal asbestosis, asbestos-related pleural abnormality, or benign pleural plaque is very most common. and lung carcinoma and pleural mesothelioma. For the non-respiratory disease like peritoneal mesothelioma, extrathoracic cancer, and rarely is copper-renal or constrictive pericarditis. This is an asbestos body in the bronchoalveolar lavage is caused by protein and ferrous we can call ferruginous body. The most common type of asbestos is serpentine or serpentine. 90% of commercial use, the appearance like a cotton, like a curly and flexible, so it can easily to inhale to through respiratory system. How to diagnose? History: sputum or bronchoalveolar lavage will show ferruginous body, and radiology. The most effective is HRCT. The lung can show irregular or lining opacity in lower field. From this X-ray, show a few reticulonodular opacity in the lower lung base. And the pleural is shown thickening or calcification along the pleural, lower lung field, calcified supradiaphragmatic or pleural plaque. This is from HRCT. White line is septum line or fibrotic. And intralobular opacity is black arrow. For the lung carcinoma, it depends on level and frequency and duration of exposure, but it's very important is smoking history is synergistic for increased risk of bronchogenic carcinoma for 60%. So please advise the patient for smoking cessation. And malignant pleural mesothelioma is repeatedly invasive and poor prognosis, but it's rare. Smoking history is not related. Which occupation? First one is roofing and falling material for construction worker. Firefighter asbestos used to make protective fire fighting clothes, helmet and boots. And this is the brake pads and gaskets, power plant worker and shipyard worker. Question number 8. A 52-year-old female working in the sand infiltration segment in the brick production unit presented with breathlessness, dry cough, on and off for 6 months. X-ray showed this one. Oh my god, horrible X-ray. It's like a COVID-19, like a TB, miliary TB or something like that. What are the comorbidity and complication can be developed from this disease? A. Tuberculosis. B. C. C. Fungal infection, and D. All of the above. The answer is D. All of the above. The diagnosis is silicosis. Is a reversible fibrotic lung disease caused by inhalation of crystalline silicon dioxide or silica, and the macrophage in the lung. It's activate the cytokine, many cytokine, and will aggravate the fibrotic lung diseases. The type of silicosis, acute silicosis, is overwhelming of exposure of highest silicon, latency of week to 5 years. 2. Accelerated silicosis is high exposure, latency 5 to 15 years. And 3. Chronic silicosis is latency more than 15 years. Diagnosis is history, clinical, and radiologist X-ray. Acute exposure will show ground glass appearance, or simple silicosis will show that small nodule predominant in upper lobes. Patient often asymptomatic. Please remember, silicon is the ground, so will show ground glass appearance, and it cause of upper lung. But the asbestosis is making a floor a roof, so it's deposit of lower lung. and chronic exposure will show nodular opacity. Nodules will show concentric layer of collagen with or without central cavitation. This is a complicated silicosis or progressive massive fibrosis. It's a coalescence into a large nodule or masses with retraction of upper lobe. And tuberculosis is very most common complication, but CA lung and fungal infection is the comorbidity and consequence too. And the potential like experted foundry could turn ceramic industry, abrasive blasting, and construction. This is my resources. And take-home message for today is arsenic, silicone, and asbestosis is a carcinogen in human. And we please counseling the patient for a smoking cessation in the asbestos worker. Thank you for watching my video. Bye.